and especially rings. For that, I invite Dr. MAHIPAL SACHDEV to speak, especially the role of rings, hooks, and segments in the management of subluxated cataract. Dr. MAHIPAL.
Thank you very much, Dr. Rajiv Chaudhary. It's always a pleasure being among friends and colleagues for this particular course, which is very successfully conducted by you over the last several years. I'll be talking about the role of rings, hooks, and segments, and my task is slightly easier with the previous speaker, Dr. Joshi, having given the basis for when you need to put and what segments, etc., you need to put. The basic aim, as I would say, is to preserve the capsular bag, and this minimizes vitreous loss and allows the placement of a PCIOL, reduces the risk of retinal detachment and glaucoma, and the lens remains in position. Now, the first and the foremost important thing is that you need to have a good pre-operative assessment and also assessment in the supine position, ultrasound biomicroscopy to gauge the extent of zonular loss is also something very, very important. So this is, you can see in the picture, clinically obvious subluxation. Phacodonosis, space irregularity in the space behind the iris and the lens, and lens edge can be seen. You have to ask the patient to look into extreme gaze. Plus, you should take the history, specifically a history of trauma. Now, when you're looking at these type of cases, there could be trauma as one of the leading causes. You could have Marfan's, homocystinuria, etc., which are the other causes, which are because of issues which could be metabolic or developmental, pseudo exfoliation syndrome, long-standing glaucoma, uveitis, high myopia. These are the important causes why you have subluxation in patients. Now, as was said by my earlier speaker, the extent of subluxation, the etiology of subluxation is something which is very important. Supposing you have a traumatic subluxation, usually it does not tend to progress, while you have a case of Marfan's. Under those circumstances, you are 100% sure that the subluxation is going to progress. And then when you are managing the case, you have to look at the grade or grade of the cataract. So this has already been spoken about. Subluxation, the extent is the next thing. So why it was there, the extent, CTR less than 3 clock hours, or the IOL haptics can take care. When it's 3 to 6 hours, you need a CTR and a ring fixation, or a glue could be the other one. When it is more than CTR, the ring has to be fixed to the sclera, or you go on to the glued IOL. And if it is more than 180 or 200, you need to go in. I have written glued IOL, but you can go in for a Yamane technique or any other technique that is to have the lens fixated onto the sclera. Now, what is very, very important in all those cases is that when you are having the challenges faced is the creation of an intact capsular axis. That is very crucial. Excess lens mobility and tilt and displacement makes the capsular axis difficult. And any discontinuity of the capsular ring is a contraindication to the placement of a capsular tension ring, because the rip which is there in the anterior capsule is going to extend and cause a problem. So there is again the problem of continuous vitreous hydration that happens during phacoemulsification in the eyes, and the hydration results from communication between the anterior and posterior chambers through this zonular deficiency, and this causes a positive vitreous pressure and shallowing of anterior chamber. So how can we make this easy? So let's just first talk about the two things that we are wanting to look at. One is the capsulotomy, and the second is the upthrust of the vitreous that you have in these particular cases. Let me show you a patient who had irregular AC. Patient had an attack of angle closure glaucoma that you can see. There is sphincteric atrophy, mid-dilated pupil is rigid, that is there. And you can see in this particular case, there is a peripheral iridotomy that has been done. And this is the sphincteric atrophy, which you can see is there in this particular case. You can see that there is an irregularity in the chamber depth, and you can see that this is a phacodonosis, which you can see very clearly. So you can see this phacodonosis. So this is a tough case for anybody to kind of take care of, to be able to do a phacoemulsification. So with the immobility, the mobility, of the capsule, doing a capsular axis becomes a problem. In this particular case, there is a Malugin ring that has been implanted. You can see that the iris is more down here. So this is where you are going to have a problem in this subluxated. So you can see that this is a femto procedure that is being done. And as we go ahead with the femto procedure, after the OCT that is done, you can see the capsulotomy and the nucleotomy. This is the capsulotomy that has been completed. This is the fractionation into various segments happening. So the important thing is that you will get a great capsulotomy in this particular case. And a femto is, I would say, a treatment of choice where the subluxation can be managed with a femto laser. So this is something which I wanted to show you, the power of femto in these particular cases. Now, once the procedure has been done, you can see here, this is the Malugan ring which is there. You had a good capsulotomy. The hydrodissection needs to be gentle, and you do not need to rotate the nucleus very forcefully because there will be a problem in these particular. So you can see that there is a stickiness because the hydrodissection has not been done to the extent that we wanted, and the pre-chopping has been done. Now what happens is that it's better to use capsular hooks here, but since we did not have capsular hooks, this is an iris hook that is being used. We are putting it and this will help hold the capsule in position. So you can see that this is now holding the capsule, and this is a pre-chopped nucleus, and the amount of manipulation that you will do to remove the nucleus is going to be much less. So pre-chopped nucleus after a good capsulotomy, taking a capsular hook, and you can see that we are able to remove the nucleus pretty well. Let's go a little forward. You can again see that there is a problem here. This is the huge dehiscence which is in this particular case. So ideal is that we should keep it compressed with the viscoelastic. Again, we have put viscoelastic, and there is a second hook that we are putting to stabilize the capsular bag. So friends, I have shown you here the iris Malugan ring that has been put, a capsulotomy that has been done, a nucleotomy that was done with the femto laser, and then we are using capsular hook, iris hooks in this particular case to support the capsule. And you can see here that we are able to, with this support, take out the entire entire epinucleus. Then the nucleus is being taken out, and you can see that we have been able to maintain the capsular bag. Now comes the time to have a stabilization of the capsular bag for even the post-operative period. So this is an endocapsular ring that has been put, and once the endocapsular ring has been put in the bag, implantation of the lens can happen, and now the hooks and the Malugan ring would be taken out, and we will end up, and this is a way to take out the hook from the other side, and this is the ring that is being taken out. So this is what I am saying, to look at whether there is any vitreous, just doing a cleanup of the vitreous tag that had come from the side. So the femto assisted cataract surgery is not dependent on zonular countertraction for capsular axis. It is done in a closed chamber and allows lens fragmentation. Now this is another case where we have a subluxation of a cataract in a doctor who came to me from Patna, 44 years, post-traumatic. And what I will again show the power of femto in this particular case, and I will show you how we decompress the vitreous in these cases. So here you can see that this is a blob of vitreous. You can see this entire vitreous coming. There is the iris falling back. And now we are going ahead doing the capsulotomy. We are centering it to the place where we want to center it, so that even once we have the entire thing moving with the ring coming in, things will be fine. So this is the femto procedure, the LRI that has been done. And now what we have done in this particular case is that we have gone for the pars plana, used the trocar cannula, and we will remove the vitreous that is coming in front. So this is a decompression of the vitreous that we are doing beforehand. So you can see we have used tricot and it is a huge subluxation which is there. And this is where, even despite the vitreous coming in, the femto procedure has given you the power to get a good capsular axis, which is very, very important to do these cases. Now, vitreous decompression has been done, and we have put in an endocapsular ring. So it is a pure endocapsular ring that we are putting here because it was a traumatic subluxation. We don't expect it to increase. And this is the nucleus being taken away. You can see that the nucleus goes off. We are removing the epinucleus by manual IEA, putting viscoelastic, not allowing the capsular bag to come forward, and then a 3-piece lens that has been put in this particular case. So you can see that this is the way you have to do a vitreous decompression in these particular cases, and go ahead and use a posterior approach to remove the vitreous. This is the final removal of the vitreous, which we will now take out from the anterior approach and close this particular case. So this is the post-op. So vitreous decompression, whenever you are having subluxations, is something which is very, very important for you to do. Now, this is again in another case where there is a subluxation. You can see here we are not doing a femto. Look at the mobility. Can you see this capsule getting stretched? Can you see this? This will not happen in a femto, but then you can use either 2 forceps, micro forceps, or you can use 1 and have a good capsulorhexis that is required. Now, in this particular case, hydro has been done, but again, you use hooks. So these are the hooks. Again, capsular hooks, we often just go ahead and use the iris hooks, as I've said, but capsular hooks can place the whole thing, and then an endocapsular ring will be placed. This is a softish cataract, so there is no real problem in going ahead. So these supplement each other. The hooks and the endocapsular ring actually supplement each other, and you are able to get good outcome. Now let us just see what our colleague Dr. Suvain has done, and this is 10 times thinner than any other ring. This is the BX, and you can see how very flexible, and it goes through a very small incision. So you don't really need to enlarge the incision, and this is the Bhattacharjee ring that is there. You have these holders in place, and you can put these holders in place, and you can go ahead and you can do a femto procedure in these particular cases. Here you can see a femto procedure is being done, and at the end of the surgery you can remove this. The other thing that is there is that if there is aniridia, there is loss of iris tissue, whether it is cataract, pseudophakia, phakia, there is photophobia, glare, sensitivity, contrast loss, etc. You can use aniridic lens. You can use these segments, small segments, or you can use these windshield wiper type of segments. So there you have to put 2, you put 1, and you put the second, and you can close it. These come in various sizes where you can have this extending right up to the center, leaving behind 3 millimeters or leaving behind 5 millimeters. It is your choice. This is a segment that is being implanted. You can see this is the segment that has been implanted. And you can see this is our case where we have put 2 of these aniridic segments, not segments, I mean the whole ring, and they look like a wiper effect where one and the other go and match, and you get a good outcome. You have to be careful that the pigment stays and it does not leach and does not cause any inflammatory reaction. These are iris prosthetic systems which are not available in India, but they also give good results. This is the first
MAHIPAL, sum up, please.
Last. So this is the scleral fixation of the aniridic lens, where you can see this is an eyelet, and you can go ahead and put these aniridic lens into the eye, but you need a large incision of at least 10 millimeters for the lens to be put home. So finally, the take-home message is that whenever you are doing a phaco, there has to be low fluid settings to prevent surge or fluid into vitreous cavity. Tamponade the area of zonular defect with dispersive OVD. Femto-assisted capsulotomy would reduce the risk of further complications, and the procedure of vitreous decompensation that I have shown, it allows safe phacoemulsification. Thank you very much for your kind listening, because these difficult situations often yield the most gratifying and the best results if you have these small little toys with you, as I would call, which could take care of this problem.